Good morning, everyone. I'm Councilwoman Felicia Porter, representing the 10th District and Chair of the Public Health and Environment Committee. This is just a reminder to you all to mute all cell phones. Joining us today are Councilman Mark Conway, 4th District.
Thank you, Madam Chair.
We have Councilman Mark Parker, 1st District.
Thank you, Madam Chair.
We also have Councilwoman Odette Ramos from the 14th District.
Thank you, Madam Chair.
We have several representatives from the Mayor's office and the City Council's office here, and the committee staff person is Marguerite Curran. On today's agenda, we'll be having two bills, one a voting session. The first one dealing with Council Resolution 25-0005R, informational hearing, availability of naloxone in public buildings, for the purpose of requiring the city administrator, Commissioner of the Baltimore Health Department, and the Director of General Services to appear before the City Council to present an assessment of the city's readiness to comply with the provisions of Chapter 764 of the Acts of the Maryland General Assembly of 2024, Emergency Services, Automated External Defibrillator, and Naloxone Co-location Initiative, requirements for public buildings, by updating its health and safety protocols for all city buildings. Now, I'm going to have opening remarks from the bill sponsor. Councilman Conway?
Thank you, Madam Chair. We had a hearing about this a little earlier and appreciated the robust conversation. I'm not really satisfied with the progress at that point. My understanding is that the city continues to make progress toward that end of making sure that naloxone is available in every city building. If I recall from that last hearing, we were told that part of the holdup was we were waiting on the state to tell us what buildings to put it in. So I'm eager to hear what progress we've made since that first hearing. And I think we know how important this issue is. We know how important it is to have naloxone available in those brief moments before someone succumbs to opioids. And so I'm eager to hear what progress we've made since and how we look forward to sufficiently providing naloxone in all city-owned buildings. So with that, thank you, Madam Chair.
Great, thank you so much. And so for this voting session, just to clarify, with regard to any questions, it'll be directed to the agency. So we'll start with you.
Sure. So in the last meeting, I guess this will go to maybe MOGR or DGS. We talked a little bit about what was holding us back from making sure naloxone was available in city-owned buildings, maybe to the health department. I'm not sure who would be best to answer this question. What has happened since the last meeting?
I'm happy to kick it off. Good morning, everyone, Madam Chairwoman, members of the committee. Julia Roche, Legislative Affairs Director from the Baltimore City Health Department. For those of us, I know we've got quite a few members of the public in the audience. So for those of us who didn't have a chance to be at the last hearing, I can just give a very quick summary of the state law. So the state law actually created a state program. And it requires the state to place naloxone with AEDs in certain public buildings. And they actually very clearly defined what public buildings those are. So those are public gathering spaces of recreation, like parks and rec centers, mass transit hubs, and the third one, to be honest, is escaping me right now. So they've defined where they're going, and when you think about what those places are, they're places that people are most likely to be. So they are the places, where it's probably most effective to have that naloxone co-located there. And something that's excited about the bill is it's not an unfunded mandate. It actually also requires the state to fund the program using state opioid restitution funds. So the state is working on that. And I think, though, in terms of progress, perhaps MOGR and BC Moore could speak to the really exciting development that we just happened this week.
Good morning, Nina Themlis, Director of Government Relations for Mayor Scott. So on Monday of this week, Mayor Scott joined representatives from the MTA, our Director of Overdose Response, and some elected officials for a naloxone box that has been placed at the metro station at Penn North. So while this does not speak to the overall statewide implementation of the law, we do now have a new box that is located at that metro station. And so that will be a pilot program that will be expanded based upon usage. They'll be monitoring the box to make sure it's replenished as needed. And we just look forward to continuing to work with the state on implementation and placement of naloxone across all of our city buildings that require placement. Thank you.
So in the packet, there's a list of, I don't know if these are all city-owned buildings that would fall under the state law or not, but it lists a number of city-owned buildings that are said to have naloxone available, and whether or not they are public-facing. For instance, it gives Baltimore City Police Headquarters. I think it's a really good idea to have it available there. Obviously, our officers are on call and ready to go, and I would imagine also all police officers carry naloxone on them. We list all the districts here. Health Department headquarters, it's good. Baltimore City Hall. The question I have, though, is if someone were to come through the door right now, do they know, like, it says that it's available in the building. It says it's a public-facing building, like City Hall, of course, is. If I were to go to a nearby AED, would I see naloxone there right now?
So as Julia mentioned, the state law requires specific buildings and the state is responsible for placement there. So as that actually gets implemented, as we receive naloxone to be placed, we will follow the state mandate as to where they'll be co-located. The city doesn't have a separate policy for co-location, but anywhere that that the state bill requires placement, those an individual would be able to find naloxone alongside an AED.
So, yes or no, if I went to the AED on this floor or on the first floor, would there be naloxone available?
At this moment, no.
Okay. And we're waiting on the state implementation?
Yeah, the state law requires MIMS to work alongside the Maryland Department of Health. They have procured the naloxone. The distribution hasn't yet been completed. So we're working with our state partners on that distribution and co-location.
Do we need to wait on the state in order to just have it available on the first floor of certain key buildings? And maybe that not necessarily a question for MOGR, for the health department. I would imagine this is, we're kind of in an emergency situation. So when emergencies happen, better for us to have it available than to not have it at all. So I think it'd be very simple. I mean, I have naloxone in my office right upstairs right now on my desk. I know that. But if someone, passed out in front of City Hall, we want it available somewhere nearby.
Yeah, and Councilman, may I jump in here, please?
Sure.
So it may be an opportunity for us to have, us to come up with a few locations that you deem appropriate with regard to kind of like that beginning stage, like the front of City Hall. So we can definitely, on the committee, we can take that as a way to work as a working group. And so we can work with MOGR and the health department on those key locations if you like. But I want to just reiterate the reliance on the state law, because not only within the state law, that comes with procurement as well. And so that what I believe is the issue, the crux of the issue that's happening here. And so maybe we can figure out a few locations in preparation for the implementation of the statewide bill. Is that appropriate?
I do think it makes sense for us to identify some locations and to immediately put out naloxone.
Sure.
Naloxone is incredibly cheap. I mean, we have it all over the place. I think once we identify those locations, I don't think
Yeah.
there's a need for us to wait on the state to
Oh,
give
yeah, no,
us-
I'm not saying that. So I'm just
Yeah.
saying, so what I'm saying is a compromise from what Nina was saying as far as waiting for the statewide implementation, but also using this committee as a working group. So if you do have particular locations, we can work to kind of see where those locations are, and then we're able to put naloxone there. So that's an intermediary, intermediary before statewide implementation, so we're not waiting.
So to that effect, do we have a sense of how many locations would be appropriate? I'd be happy to, make a recommendation based on data.
Sure.
Where we're seeing overdoses, where we have city infrastructure or buildings nearby, and make recommendations based on that, where we may want to do it sooner rather than later and not wait on the state.
Yeah, I would be more than willing to entertain that. Yeah, I would be more than willing to entertain that, and I think that there's going to be a balance. Just want to put that on the record. There's going to be a balance of maximizing those locations with regard to making sure that we are hyper-focusing on those areas of the city or those city buildings that have proximity to overdose. So I would be more than willing to entertain it.
Okay.
Okay, and so as an official committee, yes, ma'am, I see it, thank you. As an official committee request, let's start a working group, just maybe next week. Let's get all our teams together, see what those areas are in the city that you have, and then we can go from there with figuring out where we put them in at.
I'll save the working group. I can
Oh.
send you a list of locations by the end of the week. And my hope is that, within a month from the date that you receive those, we can identify whether or not it's appropriate to put naloxone and place naloxone at those locations and,
Sure.
and do it within a month.
But I definitely want to have a working group because I want to understand your methodology for those locations. And so, again, the official committee request would be to have a meeting within a week with all of our offices. Definitely appreciate the list of locations, but I think that to triangulate this conversation and understand your methodology, I think it will be helpful to have the health department and MOGR in my office there as well.
That's fine.
Thank you.
Thank you.
Great.
Thank you, Madam Chair.
Thank you so much. Any other questions? Councilman Torrance, thank you so much and welcome.
Thank you, Madam Chair. I just want to add to the conversation because city schools already provide naloxone in every school building, and it's next to their AEDs. And because we technically own their buildings, I think we should consult city schools because their Narcan is next to the AEDs as well as the first aid kit, which is the natural place where someone would travel to if someone's having an emergency. So I would say include them in that work group too, because that would impact their buildings because we have ultimately owned them too.
And so, Councilman Torrance, thank you so much for that. Do you have a recommendation of a point of contact?
I would just go with their chief operating officer or the director of home and hospital because that is the person that usually implements most of the health issues.
Great. Is that okay with you, Councilman?
Yeah, that's fine.
Okay, perfect. Any other questions, all? All right. Councilman, did you have any other last questions before we go into a voting session?
No, just a quick statement. Just given the urgency here, given how well we know naloxone works in saving lives, I want us to move quickly on this matter. This bill's been out there since, well, the bill passed last year, but the bill that we introduced here, this resolution, has been out there since February.
Sure.
And I really want us to move expeditiously to make sure it's available. So appreciate you bringing this back up. Appreciate the discussion and look forward to the work group.
Sure. So we can commit to, let's do a month from the working group date. So we'll get those list of locations from you by Friday. We'll have the working group next week, and then a month from now, we'll have them at the locations. Does that sound like?
That sounds great.
All right, great.
Thank you.
Thank you. Is there a motion to vote on Council Bill Resolution 25-0005R?
So move.
Great. We have a motion by Conway, second by Ramos. Porter, yes. Conway?
Yes.
Parker? Yes. Ramos? Yes. Torrance?
Yes.
Great. We have 5. Bullock absent and Dorsey absent, and we also have 5 yeses. So thank you so much. This motion passes. This resolution will go to second reader at the next council meeting on November 10th. All right, we'll go into the next one. Council Bill 25-0014, Emergency Medical Services, Administration of Buprenorphine, for the purpose of requiring the Baltimore City Medical Services to provide buprenorphine to all emergency medical services technicians, allowing emergency medical services technicians to administer buprenorphine to an individual under certain circumstances, and defining certain terms. I will cede my remarks to Councilman Conway. Sir, you have the floor.
Thank you, Madam Chair. Once again, welcome the conversation, the brief one just this morning around naloxone. Of course, expanding access to naloxone is a good policy, and every life saved by it is one more chance at recovery. But the progress we make here cannot hide what just happened to another measure, or what is happening to the buprenorphine bill that we're considering right now. That bill would allow Baltimore paramedics to begin treatment for opioid withdrawal immediately after an overdose. The science behind it is sound. The state has already authorized it, and the city's own fire department has already begun implementation under state supervision. Yet, from the moment it was filed, the bill has faced resistance from the administration. Months later, the same bill the mayor publicly opposed was declared legally insufficient, and that timing is not a coincidence. The policy the executive could not defeat on its own merits now seeks to be undone through process. In January, the Baltimore Banner quoted the administration calling the proposal irresponsible and simplistic, arguing that it is an exceedingly complicated issue that deserves more careful consideration than is reflected in the bill draft. Those were not words of a neutral administration. They were the opening statements of a political argument, one that has now been codified through the law department. Months later, the same bill the mayor publicly opposed, a policy that the executive branch could not defeat on its merits is instead being undone through a due process, and what should have been a policy debate has been converted into a pocket veto, one that cannot be appealed, amended, or voted on. This is what I mean when I speak of lawfare, the use of legal procedure as a political tool. When the law department's opinion begins serving the preferences of an administration rather than the laws of the city, the foundation of a co-equal government begins to erode. This is not a disagreement about one bill. It's a warning about the slow institutional collapse where accountability is replaced by hierarchy and where independent branches of government defer to power rather than principle. It's really hard to sit silent while this happens. The law department is not an arm of any single office. It exists to safeguard the city's legal integrity as a whole. And when it begins to function as an instrument of the executive control, the council's independence becomes a formality and public trust begins to fade. Each time this pattern repeats, the space for general legislative authority shrinks. Every delay in expanding treatment means another Baltimorean lost to overdose. Every medic who receives the same person twice in 1 week bears witness to what inaction costs. The science supports buprenorphine. State law supports buprenorphine. The moral imperative supports buprenorphine. What stands in the way is politics. The path forward is uncertain, but I won't abandon it. I still intend to urge full implementation of buprenorphine across our emergency medical system, but this moment could force us to confront a larger truth. A bill grounded in data, supported by the state and backed by public health experts, was quietly halted, not through honest debate, but through procedural maneuvering. That should concern every member of this body, because if the council allows a legal memo to carry the force of a veto, then the laws of the city will no longer be written by its elected representatives. They will be subject to administrative permission, and that's not how self-government works. I remain committed to seeing this policy enacted, whether through new legislation, oversight, or direct coordination with the state. But I urge my colleagues to see what this episode represents. The fight for buprenorphine is about saving lives. The fight for this council's independence is about preserving democracy itself. The question before us today is not only how to save lives, but how to defend the integrity of this council. With that, thank you, Madam Chair.
Thank you so much. All right, next we'll go into public testimony, so we'll get started. For those that this is your first time visiting the Public Health and Environment Committee, we bring public testimony first, and so we allow the public to address us, and then we'll go into agency presentations after that. So I'm gonna start with Darcy Garber from Baltimore Harm Reduction Coalition. Okay. Did you want to speak now or no? For this bill? No, for this bill. Okay, perfect. All right, next I'm gonna go into Lauren Reck from Matt Clinics. And welcome to the chamber, ma'am. It's good to see you again. You have 2 minutes. And if you press the right button, and then if you can address yourself for the record.
Okay. Thank you, Madam Chairwoman and the members of the committee for giving me the opportunity to talk. My name is Lauren Reck. I'm the program director, the founder and one of the owners of Matt Clinics. I'm also a Baltimore City resident. We are the largest office-based opioid treatment program in the state of Maryland. We have about 2,200 patients and have treated over 10,000 people struggling with opioid use disorders over the past 9 years. We have 8 offices across Maryland and a new mobile treatment unit that I'm pretty excited about. Over 75% of our patients have Maryland Medicaid. We provide medication-assisted treatment, or MAT, using buprenorphine, naltrexone, and the long-acting injectables. We also do psychiatry, mental health, substance use counseling in groups, and 24/7 case management. So I started Matt Clinics because I believe buprenorphine is a life-saving medication, and anyone with an opioid use disorder should have access to it. It's a safe, effective medication, allows people with OUD, or opioid use disorder, to lead normal lives. It has a ceiling effect on respiratory depression. It's very hard to overdose on it. It has a very long half-life, over 36 hours. It blocks the receptors. So when people are on buprenorphine, if they use opiates on top of that, they don't feel the effects. It occupies the receptors, so it alleviates withdrawal and cravings. And it's a partial agonist, so people don't feel euphoria. They feel very normal on the medication. I don't need to tell you that Baltimore City has the highest overdose fatality rate in the US right now. That's a very sobering thing to say. But what can we do to lower that number and save lives? We know that medication-assisted treatment saves lives. People need access to quality care, but we need to be initiating medication-assisted treatment in the emergency departments, and we need to implement EMS-initiated buprenorphine. After an overdose, reversed using naloxone, patients are alive and breathing, but naloxone has also triggered horrible withdrawal symptoms, including things like hot, cold sweats, anxiety, vomiting, rapid heart rate. They say patients who've experienced this say that it feels like the flu times 1,000,000. Their inclination is to leave
You have 30 more seconds, ma'am.
Okay, their inclination is to leave the scene. The naloxone, though, wears off in less than 2 hours, so they can re-overdose again. Our patients don't want to go to the emergency department. They aren't confident that their withdrawal symptoms are going to get alleviated there. So this is the perfect time to start people on buprenorphine. The receptors are empty and ready. It's got a long half-life. It's going to stay in their system, and then you can connect them to treatment, and this starts the road to recovery. It's cost-effective. I can connect you to, I've been in contact with the people at Cooper Hospital in New Jersey who were the pioneers of this program, and you can talk to them about their experience and how they made this happen. But
Thank you so much.
thank you very much.
Thank you. All right, we have Jay Uncle. Did I pronounce your last name right?
It's Unic, but
Unic, I'm so
everybody,
sorry.
no, everyone mispronounces it, and that's fine.
sorry.
So, wait,
And
what
you
do I do
have,
here?
yep, right there. And if you can address yourself for the record, sir? Oh, it's already on. There you go.
Thank you, guys.
You have 2 minutes.
All right, my name is Jay Unic. I'm a professor at the School of Social Work. I'm also vice president of the Behavioral Health Leadership Institute, or BHLI. Thank you for bringing me here today to talk. This is an issue that I'm particularly passionate about. I've spent 25 years working in harm reduction and expanding treatment access. One thing that we know, and that has been very clear through every step of this epidemic, is the moment we give people access to buprenorphine, the lower the threshold for buprenorphine access, the better the recovery outcomes, the lower the death rates, the more people that are able to get their life back, become employed, engage with their family, and other important recovery outcomes. Low barrier access to buprenorphine reduces overdose deaths. It keeps people out of emergency rooms, and it helps people begin their recovery. Research has been very consistent in this, that buprenorphine immediately after a non-fatal overdose reduces not only overdose deaths, but all-cause mortality. Low threshold programs also reduce emergency department use and get people engaged in long-term treatment at places like Mac Clinic. Pilot programs that do the same kind of thing have shown that they are safe and effective, consistent with what was just presented in testimony. At BHLI, where we have the van that sits outside the jail and is a mobile clinic that goes around the city, we've served over 11,000 people this year, 8,000 clinical encounters, and we can't provide enough service. This is a van that sits out on the street and is low threshold, right? Like people can walk up. The whole purpose is designed for people to exit the jail and immediately come to us, and we can't provide enough services. There is high demand for buprenorphine at the lowest possible threshold. The people we serve are the same people that would be served by this program. They're folks that are homeless, exiting incarceration, people that are uninsured. And so we know that this population can take advantage of these low threshold buprenorphine programs, but we have to be able to provide them. That's why I support the use of EMS as an opportunity to do this. Thank you.
Thank you so much. Next, we have Drew Fuller. Thank you. If you can state your name for the record, and you have 2 minutes.
Yes, hi, I'm Dr. Drew Fuller. I'm a specialist in addiction medicine, emergency medicine, public health, and patient safety. I had the honor of practicing medicine in Maryland for 30 years, and 15 of those years are right here in Baltimore City. And in that time, I served as an emergency physician and even the director of patient safety for Johns Hopkins Bayview. I went into emergency medicine to save lives, to be quite frank. I went into addiction medicine to save lives and to save families and to save communities. And we have so many of these pieces in place. So I don't want to repeat what's already been said. I fully support what Lauren has said. I fully support the other testimony as well. And if you look at this from the lens of patient safety and public safety, it's one of the safest initiatives that we can actually do and one of the most effective initiatives we can do. And it's not that novel, right? This is being done in other parts of the country, but this is our opportunity now in Baltimore to lead and not to lag. And we have great systems in place. I know the leadership of MIMS and the Baltimore City Fire Department, they're ready and eager to go. What they really need is funding and opportunities to bring the people on board and make this a reality. Because to provide buprenorphine on an EMS unit, there's really narrow circumstances at which it will apply, but right after an overdose is one of them. And the data has shown that if one dose of buprenorphine can increase the success rate by 600%. And we have to think of it this way. We get blinded by these stats, and I try to remind people, about 50% of our overdose victims have dependent children. So, you know, if we can save one mom, one father in those narrow circumstances, it's a multi-generational impact for not only the community and the city, but for that family. So it can be done effectively, it can be done safely, and we already have some of the best leadership in place to get this done. We just need to make the commitment and the funding to make it happen. That's it.
Thank you, sir.
You're not used to people finishing on time, was that John?
Oh, no, that's not.
I'm just
I
winging
know.
it here.
I was like, is there something else? No, you're good.
Do I
Yeah, so we'll take your testimony for public record. Thank you so much, Dr. Fuller. All right. Before we go into agency presentations, is there anyone else that would like to testify in the room?
I think we have somebody virtual.
Did they sign up?
Robert Phillips, virtual.
If Mr. Fuller, if you raise your hand, then we can unmute you. Oh, Phillips, excuse me. And now you can unmute yourself, sir.
Can you hear me?
There you are. You have 2 minutes, sir. Please say your name for the record.
Thank you very much. My name is Chief Robert Phillips. I represent the MSFA as their legislative chair. MSFA meaning Maryland State Firefighters Association. We represent the volunteer staff of firefighters, EMS, and rescue personnel across the state with about 35,000 members. I can speak to the legislative side of this. When the bill was came up in Annapolis, We reviewed it, and our position through the MSFA was to support this bill because of the positives that would come out from the use of this. The bill allowed for, and again, this is going to be your state bill, the bill allowed for monies to be made available every year for training of up to 10% of the paramedics in the state of Maryland. I believe at the time it was quoted 4,000 paramedics, and they were looking to train 10% of them to provide these services across the state. I can only attest to the legislative side of it. We're in full support of what you're trying to do. I do not know, another person might be on here. You can see his name as Eric Smothers. Mr. Smothers is a past president of our association. He was also an MSP flight paramedic, retired out of the Maryland State Police with over 30 years of experience. He could speak to you more apt than I could as to the effects and how it was used in the field and the outcomes from that. But I would say that the MSFA will be in full support of you implementing this program.
Thank you so much. All right, are there any other persons virtually and or in the chamber that want to testify today before we get started on agency presentations? All right, hearing and seeing none, we'll first go to the law department. Michelle? And if you could, for the public record, within your reports, explain why you chose that particular position as well. Oh, no worries. So within your report, if you could explain why you chose that particular position, so for the public's knowledge. Thank you, if they have not read the bill report.
Thank you, Madam Chair. Michelle Toth on behalf of the Law Department. We stand by our bill report that this council bill, 250014, is preempted by state law. And the reason is there are three types of preemption in state law. There's a
Back in session. All right, thank you all so much virtually for tuning in. We had a moment of technical difficulty, and so we're now gonna go back into our reports for agency representation. So Law Department, I'll turn it back over to you.
Thank you, Madam Chair. I was in the process of explaining implied preemption, and that is when the state has legislated so broadly in an area that it leaves no room for a local government to enact legislation regarding this topic. And with respect to emergency medical services in the state of Maryland, it is the opinion of the Law Department that they have occupied this field so extensively that there is no possibility for a local government to enact a law regarding the provision, the licensing, the training, the medical protocols for emergency medical services.
Thank you. Is that the conclusion of your report? All right, Fire Department, turn it over to you.
Good morning, Madam Chair. Thank you. Chief James Wallace on behalf of the Baltimore City Fire Department. We do stand by our report as submitted, ma'am.
Great. Health Department?
Good morning again, everyone. Julia Roche, Legislative Affairs Director with the Baltimore City Health Department. I am accompanied today by my colleague Sherika Green, our Director of Overdose Policy and Strategy. We actually did not take a position on this bill, as we really cannot speak to the MIMS protocols or EMS implementation. So we respectfully defer to the fire department as well as the law department. I do just want to mention that BCHD co-runs a mobile buprenorphine clinic that I know you all are familiar with. It's called The Spot, Healthcare on the Spot. We co-run it with Johns Hopkins. And that program does collaborate with the fire department's population health team. It's a really strong collaboration. We're really grateful to the fire department for being such wonderful partners. And in this case, if the Pop Health team identifies a patient who's interested in buprenorphine when they're in the field and the patient consents to them reaching out to the Spot, the Pop Health team will reach out to the Spot's telehealth provider and also give the patient the Spot's information. And then, you know, the telehealth provider will then work directly with the patient. So that's really the extent, I think, of our overlap with this.
Thank you so much, Finance Department.
Good morning, members of the committee. My name is Gabriel Stewart-Zykowitz with the Finance Department. I'm their legislative analyst. We took no position on this bill. We expect it will have minimal financial impact, and it'll be mostly limited to training costs. BCFD will train everyone in stages in a responsible manner in order to ensure that we control costs. Thank you.
In Finance Department, I just want to confirm, do you not oppose or do you not take position?
We do not oppose.
Okay, thank you so much. MOGR?
Good morning, Madam Chair, members of the committee. So Nina Themlis, Director of Government Relations for Mayor Scott. And I just want to kind of underscore some of what the law department's report stated. So EMS, their certification and licensure is all overseen by the Maryland Institute for Emergency Medical Services Systems. And they are the ones responsible for providing the protocols for allowing our EMS technicians to provide medical support to our residents. So during the first hearing, that was a large part of the focus. It's not as if we do not want to administer. It's not as if we don't want to move as swiftly as we can, but we are, unfortunately or fortunately, we have to follow those protocols. So earlier this summer, MIMS did issue an optional supplemental protocol. And the optional supplemental protocol, it allows for jurisdictions to either implement or not. It's up to each jurisdiction to decide whether or not they want to move forward with whatever those changes might be. And that included expanding the administration of buprenorphine to additional EMS individuals. The city has adopted that protocol, and Chief Wallace could maybe speak to the implementation thereof. But I do just want to make sure that it's clear for the record that the administration, the fire department, the health department do not oppose the use of buprenorphine by our medical professionals in the field of EMS. It's more so the preemption issue, and that we must follow those protocols. And as we implement them, we also have to have them authorized by MIMS. So when we implement, we also have to get that approval from the state every time that we implement those protocols. And I'll turn it over to Chief Wallace for some additional information.
Yeah, thank you. And members of the committee, it's as Nina said, it is a Maryland state protocol. We are governed under the Maryland protocols. We're actually licensed that way. So as those protocols dictate, we have adopted that. It initially started through the Mobile Integration Health, and it's now working its way through field providers. And it must be stressed, those are paramedics. That does not encompass all of our providers in the fire department. As a base level, the fire department, we're EMT across the board. However, we have a substantial amount of paramedics. That's where the administration of the drug would live, is in the paramedics.
And real quick, Chief, before you go, how many paramedics are administering that right now? And maybe that can go over to you.
So, good morning, Madam Chair. For the record, my name is James Matz. I'm Assistant Chief EMS. We have approximately 200 paramedics within the fire department.
And are all 200 administering buprenorphine?
No, ma'am. No, ma'am.
All right. So now we'll go into questions from the committee. So I will cede my questions to the last questions. Councilman, I'll turn it over to you.
Just to follow up on your question, Chief Matz, how many paramedics are offering buprenorphine right now?
So
of the 200?
Councilman Conway, it's a great question. I'm just going to piggyback behind what Chief Wallace just spoke of. You got to remember the protocol came in 2 iterations. The first iteration was around July of 23, and that specifically only allowed mobile integrated healthcare or like our population health unit to perform those duties. At that time in September of 2023, we were approved to do that through MIMS, and we trained our 8 people that were on that population health unit that followed that. With the subsequent approval by MIMS in July of this year, in September of 2025, we got approved to do all paramedics. We're currently rolling that out to our chase car unit, which will actually take us up to around 24 members, and the plan after that is to roll that out to our EMS officers. You got to understand, all paramedics aren't created equal. There's some a little higher, a little lower, so what we're trying to do is roll it out in piecemeal with our highest trained people. Then at the end of the day, you're probably looking at 50-ish once we roll that out. You're probably talking 6 months-ish, maybe a little more, but that's the plan as we step it out.
And so colleagues, just a reminder, we're gonna go into questions, and so you'll have 2 questions each. I'll cede my questions to the end. Councilman Conway, you'll start off with your first 2.
Sure. Thank you, Madam Chair. I want to thank the folks who came out here to testify in favor of this bill. I think it's as many of you have alluded to, it's a really, I think, obvious step for us, one that can be obviously helpful for folks dealing with opioid addiction. And it sounds to me like all folks sort of agree toward that end. And to my statement, and when we open this, the one sort of barrier right now is the law department report. And Michelle, I love you. But I am afraid that we're letting politics get in the way of good decisions here, and I'll explain why. So we talked about the EMS protocols. We talked about, in the report, it says that this bill is preempting state law. My pushback here is I believe that COMAR protects local jurisdiction. So in COMAR 30.09.03.06b, it expressly preserves local jurisdiction. It says that a local jurisdiction may regulate ambulance services within its boundaries in a manner consistent with state law. This would be state law. We are saying to accept the optional protocol which state law allows us to accept. So you're the lawyer here. My challenge is, if we know that this works, we know that this is going to have the benefits that the folks here who have testified say that it will, and it costs nothing effectively. The finance report says that if 100% of overdose calls resulted in the administration of buprenorphine, 100%, it would cost $4,305. It's incredibly cheap. So I beg of you, please explain to me why this is preemption, because I think it's incumbent upon us to figure out how we do this as quickly as possible. Certainly the fire department needs to scale up responsibly. I would never advise them to do something without being prepared to do so. But the science is very strong here. The legal argument against it to me seems flimsy. Can you please give me some more detail on why this makes sense?
Sure, Councilman. First of all, I would like to explain that under the charter, under Article 7, Section 24 of the charter, the legal department looks at legal questions and only addresses legal questions. We do not address issues of policy. So my report on this bill has nothing to do with the policy of buprenorphine. We are making no comment on that at all, and we take no position on it. The problem is, as I stated, that the state has control over emergency medical services, over all aspects of it. And that is correct. The state has authorized the use of this. It is an optional supplemental protocol that a local jurisdiction can choose to, but the local jurisdiction is the fire department in this
But the fire department
situation.
is an extension of the mayor and city council. This is where I don't agree, and I'm having trouble understanding the logic here. The bill operates within the confines of state law. It says, accept the optional state law. That's effectively what we're doing here. We're not writing state law. We're not requiring them to do something outside of what state law requires them to do. State law says it's optional. We're saying take the option.
I understand that. The problem is because of the field preemption, because the state has chosen to occupy the field with respect to emergency medical services, local jurisdictions cannot pass legislation regarding this. So this may be the best policy ever, but a local council can't pass a law that affects emergency medical services.
So the optional, in my mind, the optional is what gives us the decision. The fact that it is optional. So if there are required protocols, we can't change required protocols. They're required. They could lose their license as an EMS service if they didn't follow the required protocols. The optional ones, they could decide not to. We're saying you should not decide not to. You should eagerly work to implement this protocol.
And real quick, just for the councilman, just gonna, Michelle, if you can answer. I know we are not voting on this today. I would love for you to take this offline, so you can kind of have that conversation, because there are other aspects of the conversation related to the preemption that I would like for you. I'm going to talk with you directly from a public health perspective that you really should be focusing on in that explanation with Councilman Conway that will explain why you kind of did that. So, Councilman, I'm going to let you finish up, and if you can go to your second question, please.
Thank you, Madam Chair. I'll finish up and just say this is worth figuring out, is my point. For us to lose so many folks to opioid overdoses over the years, this is a medication that has worked in other countries very well, but for some reason we have failed to adopt it substantially here in America. So I eagerly look forward to working with you and the rest of the department to figure out how we do this, how we do it sensibly. Thank you. I'll pass on my next question for now. Thank you.
You sure? You sure? Yeah. Okay. All right, I'll go over to Torrance.
Yes, Michelle, I just want to make sure I'm clear because I was just talking to Councilman Parker about it. It is my understanding that you're saying that this council can't technically legislate it because the department in which that can implement and request permission for the optional protocol is the fire department. And then the state has delegated the authority for the approval of said protocols to Region 3, which they would have to go to actually get permission for, is what I'm understanding. All right, so this is the problem with preemptions. So legally, there is preemption for a locality to actually request an optional protocol. The only person with authority from the locality to actually request that optional protocol is the fire department, not the council, is what I'm understanding.
And the fire department did request this for the record.
Okay.
Yeah.
And then the fire department's, the person that ultimately approves the new protocol is the delegated authority of Region 3. So that is the problem right there, Councilman. When the state delegates that power, so the only people that have the most unlimited powers in this country are states and not the federal government. So basically, the state delegated its plenary powers to Region 3 to approve the new protocol. And because they have that authority, we as a council can't actually intervene in that. So they weren't solid on what the locality, they weren't solid on who could delegate it, right? They were prescriptive enough to say that it is Region 3 that will ultimately approve the optional protocol from the locality. So because they were overly prescriptive, we're limited in what we actually can say. It's just when we walk through the conversation about the just cause, while we implemented a just cause law, it could have been constitutionally upended because the state never delegated the authority to us to do just cause. And I think that's the hard part. That I just wanted to make sure that we were all on the same page, and I was trying to simplify it down to pre-K standards for everybody, because sometimes the legal perspective is this person has this thing, but now the person that really has the authority here is Region 3. I just want to make sure that was clear for the public.
And did you have any questions, Councilman?
No, I just want to make sure we were all on the same page, because
All right.
I had to literally read your report again and then
Yeah, I
think
did
it
too.
through step by step in the terms of the delegation issues.
Can I-
Yes.
So what I'm suggesting, or what I'm telling you, is this bill does not take any decision-making authority from the state. The bill says adopt the new state protocol.
But it's through an ordinance, so an ordinance is an aspect of the law. And so that's why it may be an opportunity, again, you know, the regulating body is Region 3. We are not that regulating body, so essentially, the ordinance that we're doing, we're putting it into law over the regulating authority of Region 3.
The problem with that is all that does is strip legislative authority from the city council.
It does not.
So what I suggested earlier from COMAR 30.09.03.06B, it says a local jurisdiction may regulate ambulance services within its boundaries in a manner consistent with state law. So as long as it is consistent with state law, which this is.
It is
this
not.
is not.
It is not. So the issue is, and I don't want to, again, we can have an offline conversation because we're going into the legal field, and none of us outside of one are attorneys. And so I think we should take this conversation offline, but it is not consistent. And the reason why it's not consistent is the optional nature of the protocol, which has to be approved by Region 3. We're not saying that buprenorphine is not used, it's not Lykard. What we are saying is that buprenorphine has to be used in a way that is adopting and adapting with the regulating authority of Region 3. We're not saying that city councils can't do it. What we are saying is that it has to be aligned with Region 3 as a regulating body.
I'll ask this question
Yep.
of the law department.
Go ahead.
Can the mayor compel the fire department to follow this protocol?
That is a good question. I'm not sure, but I would think, well, I don't want to opine on that without looking into it. But just to reiterate, the city council cannot pass legislation that addresses emergency medical services. So I'm not sure about the mayor.
I asked that
I would
question
have to
very
look into
specifically.
it.
If we could get some
We can get a
legal
legal
research on that.
Oh, sure.
'Cause I think the point here is if the mayor can require them to do it, why can't the city council write a law? If the mayor can require them to do something that conflicts with state law, that doesn't make any sense either.
And so is that an official committee request?
Yes,
sir?
it is.
Sure, and so as an official committee request, we're getting legal research on whether the mayor can,
If the mayor can require the fire department to comply with the optional protocol.
thank you. All right, Ramos?
Thank you, Madam Chair. Just to follow up on this issue before I get to my question, another example where I have tried to make laws about changing tax sale, and tax sale cannot be changed by the city council. It can only be changed by the Board of Estimates and the mayor, and that is just in the tax article of the state. And so it's unfortunate that I would love to be able to make laws about everything, right? We do not have the authority. We didn't have the authority to make laws about the police department until recently. And so if we wanted, you know, a lot of us would like to make laws about the school system, but we can't. So there are some things that are express powers that are given to the council that we can do, and some that we can't. And so unfortunately, this is one of them. What I've done, as you know, Councilman, is because we couldn't legislate as much as I would have liked to on tax sale, we did a lot of advocacy, and the mayor has done everything, and the Board of Estimates has done everything that we've asked so far. And so it's been a tough fight. Obviously, I've been in that fight for a lot of years. And it was frustrating that we couldn't change it here, but we're making progress through the administration, as well as through we're gonna work on getting more permission from the General Assembly soon. It's probably one of the frustrating things about being in the city council is that we can't do all of this. So I just want to say, I mean, I think buprenorphine is really, really important, and it's got to be done, and it's got to be part of our protocols that we're working on, full stop. And I'm grateful of your leadership to work through this. But you know, our colleague also talked about the Just Cause and a few others. So it's frustrating. So I don't want you to take the fact that we can't vote on this and pass this as something that is anti the policy that you're trying to make. It's just that we don't have the express powers to do it. And I'm committing to you that, you know, we can work together on making sure that everything gets, you know, implemented the way that the protocols are. So I just wanted to make that particular point. I do have a very specific question about buprenorphine. And so I'll ask the health department for this as well. My understanding from buprenorphine, and I think that we absolutely should be implementing it, you know, everywhere, but that it's doing the first dose, this first dose as we've been talking about it. How do we then make sure that that person is then going to get it? Because it's got to be consistent. And so just giving somebody the one dose right after an overdose, or what's that plan to make sure that that particular person then knows the resources, but as actually getting a soft handoff to a provider that can provide the medication full on? Because I think that is what might be missed. That's not in my, I don't know where that is right now. So if you could explain how that is supposed to sort of flow as we work through the protocols, that would be great.
Good morning, City Council. My name is Sherika Green from Baltimore City Health Department, Director of Overdose Policy and Strategy. Currently, Pop Health is working with our SPOT team, and that's how they're doing referrals for continuation of BUP. But we will continue to work with Baltimore City Fire Department to determine what is the best way to ensure that there's a warm handoff when they are inducing BUP in the field.
So we haven't gotten that far yet in the thinking, but you're working on it in terms of how do we can identify who the person is. We just gave them buprenorphine, and then you know, as I've said before, I think we need a legion of social workers everywhere. And so having somebody maybe with the Pop Health folks and with our mobile clinics to be a part of that case management approach to lead them to the next step, I don't know. I mean, I guess that's something that you're still working through.
We can certainly explore that option. However, I will say that patient data is PHI, and that is BCFD's information to hand off to us. So we do have to work on like the data use agreements and that.
Right. Well, I would imagine that you've got, you know, there's some HIPAA stuff here too. So, but I think that if we can figure that out, that will be super helpful and really get people the help that they need in a way that makes a lot of sense. I've been a big fan of buprenorphine since I learned about it years ago.
Absolutely. Thank you for bringing up that concern.
Thank you. Thank you, Madam Chair.
Thank you so much. Councilman, you have any more questions?
So many more questions, but I'm going to stop there. Thank you.
Right. I did have a question. I want to bring up, if you don't mind, I would love to bring up your subject matter guest that you brought, Dr. Fuller. And if you could have a seat at the two tables up front, I have a few questions. Thank you so much. You can come up, Lauren, you can come up too. I have a few questions. Thank you so much. So, Lauren, I want to go back because I had an opportunity to visit Mac Clinics, and one of the major issues that we were discussing had to do with peer recovery support. Can you talk to us about the time lapse that needs to happen? So if a person is experiencing an overdose, a paramedic goes out, can buprenorphine be given immediately after, or can it be, or is there a time lapse that needs to happen? And I have a second question following up to that as well.
Yeah, so Dr. Fuller could probably speak more about
Dr.
this,
Fuller,
but
okay.
I can
Either
try
one.
and answer correctly if
Okay.
I'm wrong. But after a non-fatal overdose, after naloxone is administered, the receptors are open and empty, and it's the perfect time to administer buprenorphine. It can be done immediately. It does take 15 to 30 minutes to start to work and alleviate the withdrawal symptoms, but it can be given immediately.
Sure.
And then it has a long half-life. So to connect someone to treatment, you've got about 36 hours,
36 hours.
until they're gonna be in withdrawal again.
Sure. And one of the questions that I asked, and Dr. Fuller, this may be a better question for you, with regard to the emergency services, is there a toxicology screening required before you provide buprenorphine?
No, in fact, that's often a barrier to care because you can go on the history of what the patient is telling you. I would comment on buprenorphine right after an overdose. That's go time. That is like the optimal time to give not a small dose of buprenorphine, but a large dose of buprenorphine. And with all due respect, I wish 36 hours it would work that long. It's probably 12 to less than 24 hours.
Okay.
But if you get a large enough dose,
Sure.
and then Lauren and I both concur, we believe in same day, next day connections. And there are opportunities to do it with BCOR and the Baltimore City Department of Health, and then
Sure.
a new developing system called Recovery Access Maryland down the road.
So I spoke with a few emergency physicians, and one of the major issues that they were running into, while they shared that buprenorphine was a low barrier medication, they also signaled that there's some protocols that are in place, I believe through SAMHSA, that require toxicology screening before a person. No, it's not true.
That's just their misunderstanding of it.
Oh, their
I mean,
misunderstanding, okay.
I'll share with you, I was one of those emergency docs for 15 years, giving people good luck notes, and I used to think of buprenorphine as a bridge to nowhere, to be honest with you, until I actually was convinced by the health department to take the waiver course and understand the science. And so I've been doing it for about 8 years now.
So SAMHSA is incorrect?
SAMHSA is actually, so those are actually very old guidelines. If you look through them, it depends on
It's
which one.
2023, the last one?
What's that?
I believe it was 2023.
Yeah, I mean, and I'll have to kind of go back and look at it. And they're actually trying to relax it that you don't even have to do urine drug screens as frequently. Because, I mean, I do urine drug screens every month if people are coming in, but I just send them off to LabCorp. But that's probably too much. And so if people get one every couple months if they're stable, but you definitely do not need a urine drug screen before starting. And in fact, a new standard that's developing is telehealth treatment on demand. And you're literally providing a prescription of buprenorphine for a qualified candidate by telephone.
But even with the telehealth option, there is a toxicology screen through LabCorp that it's required. Is that correct? It's a part of the reimbursable package.
It doesn't have to be.
But it is a part of the reimbursable package.
You can bill separately for the toxicology screen if you do it, but it doesn't have to be. There's no mandated package.
Madam Chair?
Yeah.
Go ahead.
So I think, while I think all this is helpful to understand broadly buprenorphine and under certain different circumstances, this is already a protocol that exists across the state, and they're already using it both here and in Frederick County.
But yes, the reason why I'm asking these questions is from a time, place, and manner perspective. And so when we're looking at the fire department, we're looking, and this is something that I have brought up to you, we're looking at the fire department and the capacity of the fire department, the capacity of paramedics. I believe that this is an opportune time to use peers. to have some sort of linkage to this system, because we have such an over capacity and oversaturated fire department and our EMS. And so that's the whole reason why I'm asking these questions, because I believe that this is an opportunity for us to build up and utilize the peer recovery support services that we have in the city to support that warm handoff within that 12 hours, but also to sit with that patient as they are experiencing.
Do you mind if I provide a vignette to support your statement? So I was the founding medical director for the Calvert County Health Department's opioid rapid response team that started in 2019. We were able to decrease the opioid overdose death rate in Calvert County by 20% in the early years of COVID, when the rest of the state skyrocketed. And it's because we had a separate program and a team. We literally mobilized when that 911 went off. We were monitoring. We mobilized with the police and with the fire, and they saw us as a resource so they can hand the patient off to us. They didn't have to be kind of straddled with all this. So I know this is not this bill. I'm just throwing it out there that that was a great program. It was expensive, and it could have been run more leanly. But when everybody else was going up and we were going down, it was only because of access to buprenorphine.
Sure. And with that access to buprenorphine, was that a direct administration of buprenorphine from EMS, or was it peers?
Neither. So it would go out with a clinician. We would take the patient, and then we'd bring him back to the health department. We would administer it right there.
So the clinician would bring. So I just want to make that
so we would take the
distinction
patient,
as well. And the reason why I'm making these distinctions, and Councilman, I definitely want to applaud you for your leadership. I think that, and for me, we're not saying that buprenorphine is not needed or not going to be implemented. What I am saying is that we have to look at the current capacity within the city government to see what can be added to the integrated team to help administer that buprenorphine. If there is peers, if it's CHWs, if it's something that can be added to the system where we are not continuously overtaxing our EMS professionals right now.
I understand that. And when you say peer, you mean like a civilian who... So a civilian would not be able to administer buprenorphine?
No.
So you mean to like help?
Yes.
Sure. I think that's a good idea. I think it would be, in addition to this idea, I think it may help with the efficacy of this idea. But I don't think it should necessarily prevent this idea from moving forward, because I think it still has it's still effective. So,
okay.
Yeah.
And so, Councilman Torrance, yes.
So I think two things can be true. I think we can figure out a way where they only have a certain number of 50 at max that are at a level that actually can administer it. And not, given our current schedule of our EMS, they're not all going to be on duty the same day. Or having the same 24-hour shifts. I think that we have the opportunity to be creative, especially with the restitution funds, and the fact that we're seeing creativity from not only the health department, but opioid restitution in terms of how we're addressing this. Maybe it's one of those things where we get in a room and start thinking about if we deploy peers as a part of a chase car that we have, that they go, if someone has an overdose, they provide them the options, and then they can transport that person to someone that can administer at the health department the buprenorphine. Then that's not overtaxing our EMS, because I'm just gonna be transparent with you, Councilman. As a husband of someone who has worked in emergency services and understand that we had our own personal issues with EMS, we have EMS sitting in hospitals waiting for bids in our ERs when they could be on the streets administering aid and support to people. So I think that if we can look at a way to expand the system and wrap our arms to actually get people to where they need to be, then we're not overloading the system. Because the biggest issue is my wife who worked in emergency medicine. So when someone's actually withdrawing, they're sitting in a place there. There's no peer there with it. There's no one there that's helping them through it. They're literally sweating and in pain because they're in active withdrawal. And this drug may only last for 12 to 24 hours. So I think that we need to be thoughtful about, if I get you connected to buprenorphine, in that time, can I get you connected to housing, the other resources that then will lead to you not being connected to the drug anymore? Just want to just opine that.
Councilman, would you like to respond?
Thank you, Madam Chair. I think, Councilman, it's very important to not conflate this additional ability for our paramedics with some additional burden, such as at hospital wait times. It's not the same. And I would also suggest that this work, helping people have some moment of reprieve to figure out what their next step is, whether it's 12 hours or 4 hours or 36 hours. Having that moment to figure out what the next best step is where you're open to considering some peer navigator or peer recovery folks who may be able to help you figure out how to take that next step in the right direction toward recovery. And I think only in those situations, only in instances where we can help people on a path toward recovery can we truly reduce the number of people calling 911 because of an overdose. If we are only responding to overdoses with naloxone, we will be sweeping sand on the beach. Those folks are still dealing with addiction. They're not getting connected to services, and they don't have that moment of reprieve to figure out what comes next because they're in immediate withdrawal. And a lot of folks will go back out there and look for their next high in order to deal with those symptoms. So if we can help them with buprenorphine, a medication that can help them stabilize and take, even if it's only 12 hours, to figure out what their next step is, that significantly reduces the burden on our paramedics, on our ALS units, even our BLS units, who see a lot of folks who twist their ankle and call 911. We talk about that all the time in the Public Safety Committee.
But I think what, and Councilman, if you don't mind, what I think the councilman is getting at is oftentimes when we have those low barrier introductions, we often see a cycle of those low barrier introductions going and spiraling. And so even if we provide the buprenorphine, there is no guarantee that they're going to get connected to service. There is no guarantee that they would go to a wonderful clinic like Matt's. What we are saying is that if there is some way to connect, bring together peer recovery support and, as if a paramedic or EMS is providing buprenorphine, creating that reduction of time and or space, that's when we're going to see true change in community. And
I agree 100%.
Yeah, so I just want to make sure we're not saying one or the other because they both have to be working together with regard to how a person achieves recovery. So, colleagues, are there any other questions before we conclude the hearing? All right, hearing and seeing none, Councilman, I'll give you closing remarks.
Thank you, Madam Chair, and I appreciate the robust discussion. I appreciate all the folks who came out to speak on behalf of this bill. I think this is a really important opportunity for our city to be a leader in new and innovative ways to connect people to buprenorphine. I mean, we literally have a truck out there that just gives it out for free. We know how important this can be in helping folks find some stability in their life and take their first step toward recovery. And this is one more opportunity for us to immediately make that connection. When someone is literally on the precipice of death and we bring them back, we have an opportunity to connect them to their very first step towards resources, their very first step toward recovery. And if we can keep them on that step toward recovery with peer services or connecting them directly to some treatment program, we can hopefully never have to respond to a 911 call for that person again. But it takes changes in systems. And I talk about this all the time. I talk about it on crime. I talk about it on addiction. It takes changes in our systems. If we treat this the same way that we've treated it for the last 10 years, shame on us. We know that there are medications available today, right now, that can change lives. And we have a bill right now that helps us figure out how to do that in a very easy, simple, systematic way. We have some legal challenges to address. So, Michelle, I look forward to circling back with you offline to figure out how we address those concerns. I have deep concerns about what that may suggest for the city council's power and what that may suggest for local control of our own fire department. So I look forward to finishing that discussion, figuring out how we get this done. There are thousands of people, tens of thousands of people dealing with addiction right now that this could help save their lives. We have dozens upon dozens of overdoses within an hour, many of which we never know about because now they have naloxone. So if we have the opportunity to intervene here, help them take that first step with buprenorphine towards recovery, my hope is that we can reduce some of the addiction across the city. And really, drugs and drug addiction are really the basis behind a lot of issues within our neighborhoods. And I know we talk about this a lot, Madam Chair. So if we can take the step toward getting people on their road to recovery, I'd be very, very proud of the progress that this council can make. So thank you, Madam Chair, for pulling this hearing together, and look forward to continued discussion.
Thank you so much.